Looks like people are coming in. Welcome, everyone. This is session 4 of the Iowa Ideas Conference. I'm your moderator, Emily Anderson, and this session is the Suicide Ideation Among Adults and Younger Generations session. It's within the Human and Social Services track. So a couple of reminders before we get started. The session does have closed captioning access, and it is being recorded. And throughout the session, audience members, you are invited to submit your questions, anything you want to ask our panelists about the topic. You can do that through Whova, and then those will be sent to me so I can bring those up and we can talk about them. A couple things with our panelists. I'll introduce all of them quickly here, but first I just want to let you know, Drew is sitting in an airport, and because of issues with muting and unmuting with the panelists, he may be unmuted for a bit. We may have to deal with a little bit of noise, but we appreciate him being here. And he may have to leave a little early. He had flights moved around on him, so he might have to check out a little bit into our session. And then Gerda as well had an emergency come up, and we'll be checking out probably around 4. And so we'll be finishing out the session just with Kelly and Carrie, and they're great. So let's introduce each of our panelists. I'll just go in order of how I have you all on my screen. So Carrie Neblett, she's the Suicide Prevention Director at the Iowa Department of Public Health. And then Drew Martell is the Chief Clinical and Training Officer for Foundation 2 Crisis Services here in Cedar Rapids. Then we have Dr. Kelly Wood. She's a clinical professor of pediatrics at the University of Iowa. She created the Suicidal Adolescent Family Empowerment Program at the University of Iowa Hospital. And then we have Dr. Gerda Bardhoshi, and she's the Director of Research and Training at the Scanlon Center for School Mental Health and an Associate Professor for School Counseling at the University of Iowa. So that's just a real brief overview for me, but I'll give each of them an opportunity to introduce yourselves as well, and also to kind of let us know what it is that connects you to this topic of suicide ideation and suicide trends in Iowa. So Carrie, do you want to start us off?
Sure. Thank you for inviting me. I'm really happy to be here and excited to talk about this important topic for our state. As Emily said, my name is Carrie Neblett, and I'm the Suicide Prevention Director for the Iowa Department of Health and Human Services. I've been in this position for about 2 years. Prior to that, I was a clinical assistant professor at the University of Iowa School of Social Work. And prior to that, I worked at Community Crisis Services and Food Bank as the Director of Crisis Intervention Services for about 13 years. So I have been doing either crisis intervention or suicide prevention more than 20 years. And I am also a suicide attempt survivor, and I have also lost a friend to suicide. So I can see it from a number of different lenses.
Thank you. Drew, do you want to go next?
Sure. I'm Drew Martell. I'm the Chief Clinical Officer at Foundation 2. I'm a site surveyor for the American Association on Suicide, and I do some private practice. I've been with Foundation 2 for about 9 years now, where I've overseen a variety of initiatives, but most of my work has been suicide prevention in the last couple of years in youth-related suicide prevention and intervention.
Kelly.
So my name is Kelly Wood. I am a pediatrician. I have been at the university since 2010. I work as what's called a pediatric hospitalist. So I care for patients who are admitted to the Children's Hospital, or I also do some time in the Well Newborn Nursery. Where I became involved with this topic is I have noticed over my years and my time here that we admit quite a high number of adolescent patients who have attempted suicide or with self-harm behavior. I've seen our numbers grow. Based upon this is where my interest in this topic came from, and led to creation of a program for caregivers, and then helping with staff to better our process and our care models on the floor for when these patients are admitted to us.
Gotcha. Gerda, do you want to introduce yourself?
Yes, my name is Gerda Bardhoshi. I am an associate professor of school counseling here at the University of Iowa. I've been a professor for the last decade. My area of research is assessment. So I've taught suicide assessment and helped supervise students for suicide assessment. I'm also a clinical mental health counselor and a certified school counselor. So the topic of suicide, especially in children in schools, is something that I am deeply connected to through my work. I also serve as a director of research for the Scanlon Center for School Mental Health. We received $20 million last year from the governor, through the Department of Education, to help schools in Iowa, particularly reducing the suicide rate and addressing suicide has been one of our mandates. And we also received $50 million from the Scanlon family to also use it for clinical services. So that's sort of my connection for being here today.
Awesome. So let's jump right in. There's been some spikes in Iowa recently in the past few years with suicides, and I know there've been it's just been a heavy topic of conversation, especially with the pandemic and a lot of other stressors that have been on people's minds. To start off, we have kind of a couple of people here that specifically work with children and others who work more with adults, and so I'd love to talk a little bit about what are the differences when we see suicide ideation and mental health struggles with adults and versus what we see with children, and how that how children and adults react differently to these kinds of stressors, and then what the different sorts of treatments needs to be. That's kind of an open question for the group, but any thoughts on that?
Sure, I can jump in first. In terms of the differences between youth and adults and suicide ideation is honestly that we don't have a good idea about the applicability of a lot of the models we have around suicide as it applies to youth. That in 2019, the NIH put out had a workshop, a day-long workshop on youth suicide, basically putting out a call for action by suicidologists across the country and academia to better understand the applicability of the models we have around adult suicide. That goes into treatment as well. Currently, SAMHSA has only one treatment protocol listed as a best practice, and that's dialectical behavioral therapy, or DBT, with a handful, maybe 4 or 5 therapy protocols listed as moderate evidence. And so strictly from a data perspective, we just don't have research and data to inform us. And the younger the youth gets, the more that becomes prevalent. So under about the age of 10 to 12 years old, we have almost no data at all in terms of what successful intervention looks like, what successful treatment looks like. Now, as we move into early adulthood, we have a lot more in terms of research and data and treatment protocols that show efficacy, things like cognitive behavioral therapy for suicide prevention, dialectical behavioral therapy, collaborative assessment and management of suicidality. And so the big struggle right now, not just in the United States, but internationally, is the lack of data surrounding youth suicide and effective protocols and effective intervention. As of right now, most of what's being done is we are applying adult models and adult interventions to youth and children.
I'd like to jump in a little bit there and talk specifically about children and adolescents. A lot of time, the signs that a child is experiencing or adolescents experiencing suicidal ideation are similar to other things, so it becomes confusing. So for example, risky behavior, an uptick in risky behavior, we tend to rationalize that as, adolescents being adolescents, but we know changes in eating or sleeping patterns, those tend to be some early signs. And also teachers sometimes will report that a student that is having suicidal ideation might write or draw about some of these topics in their assignments, or very frequently might text other friends indicating that they are thinking of leaving or giving some of their prized possessions away. Or very frequently now we see the social media posts that may be coming through that maybe adults are not aware of, but other adolescents can have access to.
Yeah, and I think just to echo on that, also sometimes we see self-injurious behaviors such as cutting. And then I think what the scariest is just sometimes there's no signs at all. And that is why just this week now there's recommendations to screen children as young as 8 or 18 for anxiety at just well child checks, even if they're having no symptoms, just because asking is better than not.
Yeah, definitely. Do those signs that kind of start to show up, those things you mentioned, do those cross over into adults with these same thoughts, with these same suicidal ideations, or does it tend to look different?
I think a lot of the warning signs are similar. but they are harder to detect sometimes in youth because of what was mentioned as far as people thinking it's a phase or a normal part of growing up. But yeah, adults also have, behavior changes, change in hygiene, mood behavior or mood disorders, giving away possessions, talking about suicide, telling people that they can't take it anymore, are some of the big signs that are there to watch for. Really, with adults, a lot of adults have ingrained their behaviors by the time that they're older, and so it's a little bit easier to notice a change in those behaviors, and that's really what we're looking for, because anything really can be a warning sign. It's whether it's detectable or not to the other people. And I have an example where a friend of mine went to a wedding for her brother-in-law, and he hugged her longer than he'd ever hugged her, and she felt it was a weird hug. And then a week later, he died by suicide. And to her, after the fact, she thought he was saying goodbye to me. But of course, she wouldn't be able to detect that as a warning sign, and so I think that people, if they do miss warning signs, it's not their fault. And I think it's important when we talk about this to make sure that people know that you only see what you see at the time. And so, yeah, but looking for change in behavior is a big one.
Yeah, definitely.
We're
So-
also used to thinking of individuals that are suffering from suicidal ideation as being sad, right? So we're used to seeing sadness or withdrawal. In young children, that sadness looks more like irritability. So you might not see necessarily, signs that we would think are typical of depression, but increased irritability, difficulty concentrating, doing poorly in school. And I think that's really specific to younger children.
Yeah, thank you.
I think one of the things worth mentioning is, as a base event in our society, suicide in adolescence and youth is rare. It's a rare event, and that's something reassuring and something that is important to mention. And that also presents challenges in researching and having a good understanding. And so going back to, we apply a lot of the rules that we use with adults in identifying suicide, and we just kind of overlap them with children without a really good empirical base, if that is the way to do it or not do it. One of the things that has gotten a lot of scrutiny at suicide in the field of suicidology, and it was mentioned, I think by Greta earlier, sleep disturbances in youth. That is something that has had kind of an increased kind of prevalence in the research around youth. It's already been kind of looked at with adults. And so one of the things we're looking at is sleep disturbances, especially in youth, in adolescence, but really we're trying to account for the accumulation of warning signs. So a mood disorder, sleep disturbances, substance use, maybe a precipitating event. And so as a clinician, that's what I'm trying to do, is I'm trying to really piece together these warning signs and overlay them with risk factors that I know about suicide, and then make a determination. It's really challenging. And even like the two screeners that I'm aware of that have some reliability and validity with youth, which is the ASQ and the CSSR, the Columbia Suicide Severity Rating Scale, I think has been tested as young as 6 years old, and I think the ASQ has been tested as young as 8. I still have a lot of discomfort myself in applying it with youth that young, and there's still a lot of kind of gaps in the knowledge there.
Drew, I love that you talked about risk factors, and it made me think about protective factors. And also, we don't talk about protective factors. You might have the risk factors, but you might have enough protective factors that, in a sense, as a clinician or schools, parents can lean into to reduce suicidal risk. So I think that's also an important discussion.
Yeah.
So define that for me. Sorry, go ahead.
Oh, I was just going to say that's a great point, and I was thinking, in a lot of the gatekeeper trainings that are coming out, there's kind of a growth in gatekeeper trainings aimed at youth and adolescents. One of the protective factors that a lot of those are built around is having a positive relationship with an adult in your life. And so several of the gatekeeper trainings or some of the new models coming out look at, does this youth have positive relationships with adults? So they have adults in their life that support them and that verbalize that on a regular basis.
Awesome. So protective factors, I guess, are just those factors that are kind of gonna, I guess, prevent's not the right word, protect, I guess, to help to reduce the risks, even when those other risk factors are there.
Yeah,
Yes,
They're
they
the
act as a
factors-
buffer. Sorry.
go ahead. You said, I love that. They act as a buffer. Yes, they will protect you from attempting or dying by suicide. And we can talk about some of those things that are, very important, like social support, academic support, family support, future goals, reasons to live, strong coping skills, strong problem solving skills. But one of the most important protective factors is removal of access to lethal means during crisis. And that's also something that the literature is really pushing hard for.
Yeah, that's
And that,
awesome.
that really can't be emphasized enough. As it comes to population level interventions, means restriction or means counseling with youth is probably the most important thing we can do. And it's worth stating that youth die with firearms just like adults do. And in fact, looking at the research, youth use firearms almost as often as adults do, which is around 50% of the time. And so if we're working with a youth who is at risk of suicide, we are not wasting our time by engaging the family in conversations around means safety. There's a whole bunch of reasons for that. There's a whole bunch of research related reasons for that, including impulsivity, the window by which an individual acts on suicide intent, which in most cases is less than 30 minutes from when they decide to end their life. And so creating distance between the youth or the adult and their identified means is possibly one of the most effective ways we currently have to save someone's life.
Awesome.
And we recognize that was one of our big areas that we were deficient when we were discharging these patients. So that has now become part of our standard care, is making sure that we counsel and we have worksheets, because there are so many things to think about and it can be overwhelming. And I agree, time is your friend in that moment, just time.
That ties in really well to a question we just got in the chat. I think it'd be great to talk a little bit about some of the resources that Iowa provides, some of the things that are available as far as those protective resources. And along those same lines, resources for family members. The question was about the roles of family and friends and what resources those people have when, or if you've lost someone to suicide, kind of what resources that are available for those who may be struggling from the other side of those things. And it says, how can someone become an advocate? What is the recommended time to get involved, considering the grieving process, reaction, and time to digest? Any thoughts on that?
I would say one of the first things to do is to spread the word about 988 for people who are unaware. It came out this summer. It is the crisis number you dial now, similar to 911 for a medical emergency. And this is for a mental health emergency. It will connect the person to a mental health crisis counselor within their state, is my understanding. So I think it's very important that we make sure people know that that is immediately available for you by just hitting those 3 numbers.
Yeah, definitely.
And to touch on the coping with suicide loss, there are a number of support groups out there specifically for that purpose. And the American Foundation for Suicide Prevention is a premier national organization that focuses on suicide loss and providing that support to survivors. They have chapters in every state. Iowa has a chapter, and I would recommend going to their website, which is afsp.org, and looking at, they have lots of literature, a lot of a bibliography that you can look at, books that you can read. They can provide you the location of those support groups. And they also do a lot of advocacy. And so the question about how to be an advocate, that would be a great organization to connect with to do just that.
Yeah, that's awesome. Any other thoughts on, oh, go ahead. Sorry.
I'm going to say, in terms of resources, our center works very closely with schools to provide them with educators with training on suicide identification and prevention. So we have several accessible, free of charge trainings that we offer online and in person. Assist is one, QPR is another one. We have done several of those trainings throughout the year, and we have several that are coming up as well. So if you're interested in participating in those trainings, the Scanlon Center for School Mental Health website, and I can pop that in the chat as well. Especially if you're an educator and you're looking for specific training for yourself and your school to help students that may be at risk for suicide.
Yeah, definitely.
And NAMI also has a lot of resources for parents and family members of people with mental illness. And they have, the different local chapters have different programs, but a lot of them do have family to family type programs where there's a lot of support and education provided.
There isn't a formal mechanism to do this, but there is a model across the nation called loss teams, and it's something we have at Foundation 2 we've experimented with at times. It's hard to maintain, but in working with people who have lost a loved one to suicide, youth or adult, one of the most powerful things I've ever witnessed is connecting them with someone else who has lost a loved one to suicide. That can be done in the right time, in the right capacity. And there are people out there, there are people in Iowa who have lost a loved one to suicide who are very brave and courageous and dedicate their time to meeting with others who have lost a loved one. That can be one of the most cathartic things we can provide to someone. And so I'm hopeful that in the next few years, we see a growth in that type of programming and access to those resources, because that might be one of the most powerful tools we have to offer to someone.
Yeah. And the American Foundation for Suicide Prevention does provide something similar to that, where they have volunteers that can connect with somebody who's lost a loved one to suicide. And I know that the part of that question was time frame as far as how long you should wait before you go into that. I believe that the American Foundation for Suicide Prevention recommends 2 years, but research, it's not based on research, it's really how you feel, and if you feel you are ready to venture out into doing some more of the helping type activities.
Yeah, of course. So speaking of resources a bit, we talked a little bit about the resources that family members have and loved ones have, but what are the resources, what are the programs that have been built out in Iowa to support people who may be thinking about suicide and who are looking to get help?
So it's not an Iowa resource, but one of my favorite resources is the Trevor Project, which aims at youth and young adults. And that is a crisis services organization out of San Francisco that specializes in LGBTQIA+, what they'll say is youth and young adults as their population. They're a phenomenal resource for individuals that are needing that type of support.
Great. Anything
Sorry,
else?
I might have lagged there too, by the
No,
way.
you're
Everything
good.
kind of froze up here. So
It's also realistic to recognize that not every child or family will have access to a licensed mental health provider in their community, but hopefully children should have access to a certified school counselor in their school. So one of the biggest resources that we see, especially in rural areas, is those mental health professionals in the schools, and accessing services through them. Hopefully the AEAs will be able to provide services there as well in terms of referral. Our center also provides short-term crisis counseling services for schools and schools and students that are dealing with crisis concerns, including suicidal ideation. And we try to link families with resources for referral after that.
Yeah.
And there's a local foundation here. It's a nonprofit. It's called the Big O Foundation. It was started by a family after a student from North Liberty High School committed suicide. They have a website that has links to the majority of these resources that have been talked about. Again, just to see a grouping of these links.
Awesome.
a resource that I also don't want families to forget about. One of the best first resources we have is a family doctor. And so when we work with someone, youth or adult, who's experiencing suicide ideation, one of the resources that we always want to connect them with is their GP. And so I just wanted to remind folks of that as an important first stop. There are organic reasons, there are psychotropic reasons that can compound suicide ideation, and really they need a medical professional to look under the hood, especially with youth, as well as for things like sleep. Sleep can be targeted with relatively low stigma in both a therapy and a medical setting, and so we want to make sure that that is one of the first places we encourage people to connect. It never surprises me when I'm working with an adult or a youth and I ask when the last time they saw their family doctor was, and they say 2 years or 3 years. And so that's a resource I just want to plant and kind of keep forefront in people's mind.
Yeah, definitely. Another question we had come up says, 3 years into the pandemic, how does the panel see long-term impacts and spikes in high-risk suicide? So how has this all kind of been affected by COVID? And I mean, there's also been other stressors, I know, the derecho and other things that have caused just economic stress for people, but specifically COVID and the pandemic and everything else going on. How is that? What do you see in the future and long-term effects from those things?
So I will answer this, then I have a plane to catch to get home to my lovely family. So we don't know, the data hasn't parsed itself out yet. What we do have data on historically is financial crisis, of which we know there was a significant one underneath the pandemic. And so, you know, after the 2008 financial crisis, I think it was Oxford did some research and attributed somewhere between 10 and 20,000 excess suicides to the 2008 financial crisis. I think it'll be 5 to 10 years probably before we have a really good idea of the impact that that the pandemic had on suicide rates. But right now, data is just starting to emerge on that. To give it, there is absolutely no question that it impacted the mental health of people across the planet in a whole bunch of ways. But its impact on suicide rates isn't entirely clear yet.
And I would say from a medical professional that a lot of COVID, it seems we learned retrospective, meaning looking back. And so I think the data's come out, mental health crises increased, depression rates increased, suicide attempts increased for adolescents, and one identified factor was isolation and being connected either with an adult or even electronically was shown to be protective. So I think isolation, like closing of schools and things like that, will have to be something that we have to be very mindful of in the future. And hopefully that won't come to that again.
Yeah, of course.
And numbers wise, I have the suicide numbers from the last 3 years, so I can kind of share how that was. But in 2019, we had 522 people die by suicide in Iowa. 487 were adults and 35 were youth. In 2020, we had 550, so a small increase. 518 were adults, 32 were youth. And in 2021, we just have provisional numbers, so they're not set in stone yet, but we're looking at 541, which is actually a small decrease in suicide.
Gotcha.
Carrie, I'm wondering about, do you have any youth specifics for 2021? No.
No, yeah, we just have the number right now. That should be coming out probably in late October. We'll know more then, but one of the things we found nationally is that the suicide rates in nationally went down in 2020, but have got, it looks like provisionally they're going up in 2021. And you know, there's not a lot of research on it, but one theory that people have is that when the whole world is in crisis, it's a shared crisis. And so everybody is expected to feel bad, and it normalizes it. And so that actually decreases the suicide rates. But what happens, and what we've seen in other disasters, is that as people start to get back to normal, that's when the suicide rates go up, because those that are still feeling bad and see everybody else around them feeling better, they start to feel hopeless. And, you know, and so that is something we've seen historically. And, you know, like I said, I don't know what's going to happen in the future, but that's historically what we've seen.
That's interesting. I hadn't thought about the idea of it being kind of that shared.
Yeah, they
shared
actually did.
situation, yeah.
They did some research on, they had people stand in ice buckets and timed them. And if they were alone standing in an ice bucket, they were able to stay in less time than if they were with somebody else that was also in an ice bucket. They could stand it longer. And so I think that relates to what we're seeing here as well.
Yeah, definitely. Another question we just got, it says, follow up to Gerda's point about rural area communities seeing an increase in high risk suicides and other mental health situations. Is there training or resources with schools, rural doctors, community centers, etc.? So basically, I think they're just wondering kind of what are the differences, I guess, in the training we have for our rural area communities that don't have as many resources available as opposed to what trainings are available in the larger cities of Iowa.
I'm not aware of any specific trainings that look specifically at rural areas, but those trainings, at least that our center provides, are free of cost, whether you're in a rural or an urban area. We do see that professionals in rural areas don't have access to the number of trainings. So that's why doing some of these things online or applying to get an in-person training is something that would recommend to rural schools. We also know that mental health providers, I believe over 90 of Iowa's counties are mental health provider shortage areas. So maybe Kelly can talk a little bit to the medical side, but we know that those healthcare professionals are also stressed because they get all kinds of concerns, including mental health concerns, and usually there aren't a lot of places to refer to.
Yeah, definitely. I mean, same challenges with even primary care providers, licensed independent providers, whether that's a physician assistant, an advanced practice provider. Rural areas often find that they're at a shortage for such services. I mean, COVID did bring about an expansion of telehealth, which is a start and can help at least for patients to get connected to services. Online trainings, schools are making trainings more of a priority. As far as like a pediatric training, anxiety, depression, ADHD are things that your primary care, at least in pediatricians and family medicine, now feel comfortable managing these conditions, at least the early steps. So yes, even like starting there, you will be able to find help in that first step.
Awesome.
And
the
state has a zero suicide initiative. We're funded through SAMHSA, and we are providing the zero suicide framework to substance use treatment providers across the state, which includes it includes a treatment provider in every county that serves every county in Iowa. And so they are getting clinical training, front desk staff training on how to work with people that are thinking about suicide in that venue. And then Iowa State University, they have a behavioral health team that focuses on agriculture and farming and suicide prevention. And they do a lot of different trainings, including QPR, and they have the ability to provide that in Spanish, which I think is a great resource for the state.
Yeah, that's awesome. There's a question here that was asked a while ago that I kind of skipped over because the conversation had sort of moved past what they were asking, but I think it's important to address. Back at the beginning when we were talking about warning signs and what we're looking for both in adults and in children, someone asked, how do we look for warning signs? Maybe you're not fully thinking about suicide yet, but how do you watch for warning signs in yourselves? How do you digest kind of moments of feeling off or feeling lost, and where do you cross that line internally to where things start becoming risky or where you should start reaching out for help?
I would say anytime that you are contemplating, having thoughts about hurting yourself, it's important to reach out to a mental health professional. Sometimes when we see thoughts of suicide can be a bit more abstract. So there might be things like, I'm not going to actively do something, but I wish I could turn my car over a bridge, or I'm not going to do something, but I might walk in the middle of the street and just hope that something happens. Or I'm not going to actively do something to myself, but I might engage in some behavior that puts me in harm's way. And that sometimes we don't talk about that type of behavior as being suicidal behavior, but it is. And also even having thoughts of, I would not want to do something to myself, but I really wish I didn't wake up tomorrow. Those are all suicidal ideation, suicidal thoughts. So talking to a mental health care provider is really important. I would also say we are now post-COVID. One of the positive things that has come out is people have been very forthcoming about some of the mental health challenges they're experiencing. I think the national conversation has moved to normalizing mental health concerns that are happening during our development and, these long lives that we live and the different phases that we go through, or crisis, personal or work crisis. So I think anytime that you feel I'm kind of at capacity, or I'm not enjoying things like I used to, or I don't have excitement about my day, or I feel alone, I feel withdrawn, or I don't have any clear sense of what my future holds. Those are all perfectly good questions and reasons to explore counseling as an option.
And I think too, that's where 988 comes into play, because you could just make a phone call or a text and say, I don't feel right. Can you help me talk through this and see if I need additional support? They are more than happy to do that. You don't have to be thinking about suicide to call 988 or to text. You can, even if you just feel bad, they're there for you to provide that support. And then one other resource that we haven't touched on yet today is Your Life Iowa. It is our statewide crisis line for suicide, substance use, mental health, and gambling. And they can do the same things as 988, but they also, their website, yourlifeiowa.org, has a lot of resources, and they actually have screenings so that you could online answer some questions to see if you may need to talk to somebody. And so that's another really great resource that's out there.
Awesome. I like this question we got a few minutes ago. It says, what is the value in cross-generational support? Older generations helping younger generations through periods of uncertainty, or younger generations supporting older generations?
I think it all comes down to someone that you have trusted support in, a person to turn to that you can feel free and open to talk about your concerns, so that they, especially if it's someone that it can be culturally responsive, your thoughts will be taken seriously. You won't be dismissed. So I think, however that connection occurs, I think that cross-generational can have a lot of benefits if you find that helpful to you.
We just came from, it was called the Iowa Best Conference that just happened over a couple of days in Des Moines. We had over 1,800 educators come and get content on social emotional behavioral health. And the keynote was Dr. Robert Brooks, and he talked about all this research that points out to what is one of the most protective things that kids can have that teaches them resilience is having a charismatic adult in their lives. And sometimes a charismatic adult happens to be an older adult. It's just somebody that children can draw strength from. And sometimes when you are in different developmental life periods, right? Maybe you're a grandparent and you've raised your kids, and maybe you're retired. So you're now in a completely different sort of phase in your life where maybe you have the time and you have wisdom and the ability to give back. That's wonderful. The same thing, children or adolescents or young adults that are interested in connecting and making connections across the generation. So the funny thing is you can have a charismatic adult if you're a child, or also if you're an adult as well. We all need charismatic people in our lives that we can draw strength from.
Thank you. I think that's a great kind of answer to that. Other things I kind of was wondering about coming into this is, are there demographic groups, one that are more at risk of suicide, and then there are other groups that have a harder time getting resources or getting connected with someone who can help them, or maybe who don't know about the resources that exist, and what can we kind of do to bridge that gap?
Well, in Iowa, 82% of the people that die by suicide are male. And hold on, I have to look up the data here. And I recently pulled some occupational numbers to see what occupations people had that had died by suicide. And the three highest occupations for males was transportation and material moving was the first one. Construction and extraction was the second, and production workers were the third. For females, it was completely different, where the top one was they weren't in the workforce. So they were either a student, they were in jail or another facility, they were a housekeeper, and then office and administration work was second, and food prep and service was third. And so those are some of the higher risk groups, specifically in Iowa. And then the other one that I think is really important is the LGBTQIA that Drew had mentioned. We just recently in the Iowa Youth Behavior Survey that we did, we had 6th graders, 8th graders, and 11th graders fill out questions, and they found a huge disparity in the suicide related questions with the LGBTQ community. And just one example that I have here is that people were asked in the last 12 months, had you ever felt so sad or hopeless that you couldn't do activities for 2 weeks or more in a row? And for straight youth, they answered no to that question. 76% said no, they hadn't felt that way. 24% said yes, they had. For LGBTQ, they said 33% said no, and 67% said yes. So it's a difference between 67% and 24% who said yes to that. And each of the questions related to ideation, plan, attempt were similar. And so that was very striking to me, and something I think needs to be addressed on a statewide basis.
Yeah.
I also want to talk a little bit about societal risk factors. So what are things that are happening societal wise that increase risk of suicide? So stigma associated with help seeking or mental illness, we know that is a societal risk factor. Easy access to lethal means is another one, and unsafe media portrayals of suicide. There has been a lot of talk about social media, and especially with children and adolescents, what kind of access they have to portrayals of suicide on social media. So that's sort of another element of risk societal wise.
And unfortunately, the same disparities we see with anything in healthcare, racial and ethnic minorities disproportionately have less access or seek help less.
Are there ways that we can kind of address those disparities for minority groups?
I think to what Drew had mentioned earlier about research, there needs to be a lot more research on how programs work with different cultural groups, and really realizing that not one intervention is going to work for everybody, and that we need to put more into those interventions that are going to work for those communities. And another thing too is that connection is so important. And the Trevor Project recently did a nationwide survey, and I don't have the numbers in front of me, but the risk of suicide went down dramatically when a transgender youth had somebody that supported them that used the pronouns they wanted to have used. And that was it. It was just that use of pronouns, and it just really dramatically decreased their risk of suicide. It was a buffer, we'll say. And so I think building that connectedness is important. And then also providing services in other languages is another thing that is going to be really important.
And
Yeah,
moving forward, diversifying our healthcare workforce so that someone can provide culturally relatable care. I know we have a psychologist who does individual therapy, which she started because she herself identifies as Black, and specifically will provide therapy for pediatric patients who also identify as color or minority, just recognizing that we did not have a wide representation of providers.
yeah.
And I do hope that 988 provides some of that access where there was limited access before, especially with maybe undocumented immigrants that wouldn't call 911 because of fear of being deported. They could call 988 and get the help that they need, as well as African American and Black youth and adults that may be hesitant to call 911 can now freely call 988 and get that help that they need.
Yeah.
And then the other thing too is that it hasn't been widely announced, but it will be widely announced in about a week. But 988 has now, if you're a veteran or service member, you press 1 to be connected to a specialty veteran center. If you speak Spanish, you press 2 to be connected to a Spanish center. And they now have a third option, which is press 3 if you identify as LGBTQ. And you will get to a specific center that specializes in working with that population. And so that's really exciting too, because I think a lot of times people don't reach out because they feel like the person on the other end isn't going to understand them. And this just is one more access point where that barrier can be removed.
Yeah, that's awesome. I didn't know that. Another question we just got in says, how do our providers take care of themselves as they are absorbing the experiences of those in crisis? In Iowa, are we taking care of those that are helping to be there for those that are at risk?
I can tell you that research out there, I will speak from a physician standpoint, that physicians are reluctant to seek care themselves because of fear for our licensure. So talks like this, there's now curriculum in the healthcare fields. I know for our physician assistants and our medical students, where there is a specific unit on seeking self-help, self-awareness, suicide, trying to increase awareness. Departments throughout the hospital are starting to recognize more burnout, the stress that has come upon with the pandemic, and doing more to bring in resources and just having the conversations. I think just the conversations and people being willing to speak up and acknowledge it helps others get help as well.
And I think that the more that the organizations can do to normalize help seeking for mental health is going to be important. Having EAP programs that are promoted and encouraged to be used is another key thing. One employer I just recently heard about, when one of their employees is going through a struggle, maybe they experienced a loss or a hardship, they will email that employee specifically and say, I'm sorry to hear that this happened to you. Remember, here's our EAP program and how to access it. This is here for you. And so just really encouraging those conversations, I think, is really important, and checking in on people that have either been really stressed out or have had a difficult interaction with a person that they may need to debrief from.
And I think events like this are important because it will help, hopefully, make someone feel more empowered when they have a sense that something might be off, to say something or ask, and not be scared that asking the questions will make someone think about suicide. And on the reverse too, if someone should come to them as confiding in them, maybe they'll remember some of these resources we talked about, so that they feel they can provide an answer.
Yeah, definitely. So we've got about 10 minutes left. So I want to kind of move to talking about the future and kind of do a quick sort of general view of what do you hope in the next 5 to 10 years that mental health care and crisis response looks like in Iowa? And what are the barriers that we're facing right now that are keeping us from achieving that ideal?
That's a big question.
Is
I think one that maybe, like we've already talked about, reducing stigma, normalizing the frequency with which people experience mental health conditions as we age in just different time points in our life, recognizing that can occur in anyone, including young children, will help us just hopefully to be more responsive. I think treatment options need to be expanded. We are making progress as far as like genetic testing to help match the specific type of medication that might be best for you. Non-pharmacological, like something called transcranial magnetic stimulation is coming about. So I think we need to continue to improve our treatment options and make them available to everybody, rather than having to be like, before insurance will cover it, as the last option when you've failed this, and this. Why can't it be the first option if you choose it? I hope that, yes, we can take the power back from insurance companies.
I think I completely agree with that. And also just everybody has access to healthcare, quality healthcare, telehealth. I would love to see telehealth be expanded for those who can't leave their home or don't have transportation. Increased transportation resources, financial resources. A lot of stress and thoughts of suicide come from financial crisis. And so providing those supports, I think, are important for people. The other thing is we currently have mobile crisis teams in, I believe it's 86 counties of the 99 counties. But they're working to get that in all 99 counties. And I think that that's really important, because instead of having a police officer show up to your door, they can have mental health professionals come to your door and do an assessment right there to see if you're okay to stay at home with a safety plan, or maybe they do feel you have a higher level of care. There's also crisis stabilization units. I'd love to see those expanded so that they are closer to the person's home, and that our crisis services all connect with one another so that everybody knows what the other person is doing. So it's kind of a continuum of care. I would love to see that. And it is something that we are working on with the funding that came with 988. We're currently working on that. So.
And as far as from like a pediatric population, I'm excited to see what the Scanlon Center will do. I think the schools are a first access point for many of our students. They've shown us like having a school clinic, at least like medical things that are screened for, and like immunization rates go up. So I think training our educators as a first point of access will be very important.
Yeah, definitely. All right, well, we're just about out of time. We've got about 6 minutes left, but is there anything regarding this topic that we haven't touched on that either of you wanted to speak about, or anything that you would just like to let people know of, any resources or any just additional thoughts about what people can be doing to improve this for themselves and for others?
I guess like we've already hit upon, but asking about suicide has not been shown to increase someone's suicidal thoughts or to make them complete suicide. So please, if you're worried, ask. Then the other thing is just another resource we have at the University of the Stead Family Children's Hospital website. There is the Suicidal Adolescent Family Empowerment Program. It used to be in person, but unfortunately with COVID, it had to close down. So now it's exclusively online. It's multimodal. It is in Spanish as well. You can watch a video presentation. There's different clips of clinical vignettes. There's handouts. There's links to resources. So, and someone can peruse it at their own time and take in as much or as little as they want. There's safety workshop or worksheets. It's homegrown, but it's another resource that's out there to anybody in Spanish and English.
And I think for me, one of the things we haven't touched on is the power of pets as a connection point. Dogs, cats, hamsters, you know, whatever that pet is, it provides two different things. One, that pet is always happy to see you and doesn't judge you, and they're really great listeners. And so even if you don't have anybody else to talk to, you can talk to your pet. And the other piece of that is it's one of the protective factors that buffers against suicide is having a sense of purpose in life. And having that pet provides that purpose for people because they have to take care of that animal. You know, who's going to feed my dog if I'm not here? You know, who's gonna make sure it gets walks and that type of thing. And so I really wanted to stress that it's unconventional, but it's powerful. And then one other resource I wanted to make sure people know about is a website called Now Matters Now. And it's a website that really focuses on teaching people quick DBT skills that they can use when they're in crisis and they need to feel better right away. They talk about feeling like you're on fire, and they're quick DBT skills that help you kind of manage that so that you can calm down a little bit when you feel like you're on fire. So it's nowmattersnow.org. I would highly recommend that.
That's awesome. Well, thank you guys so much. I really appreciate our panelists and even those who had to pop out, but I appreciate all of you being here and taking the time to share with us some of the knowledge that you've gained through your work. And for our audience members for coming, we had great participation with the questions, and that's awesome. And I'm glad that we're able to address some of those things that people wanted to know. So yeah, it's been a great session. I think this has been a great discussion. I know there are several more sessions coming up this next hour for Human and Social Services track. I believe the next session is about how nonprofits in Iowa are getting creative with their collaborations and funding to be able to continue providing services. And then obviously there'll be plenty more sessions tomorrow. So be sure to tune in and keep watching for the things that interest you to find out more about. And yeah, thank you everyone. Appreciate it.